Hello, everyone. This is Shivani Ugrin, and we'll be getting started with the webinar in just a few moments. Looks like we have many friends joining us. And let me go ahead and queue up our slide deck. A moment. Okay. I see our panelists are joining us, and we have many attendees signing in. Wonderful. Welcome to our webinar. Okay. Thank you for joining us. We are excited to share some of the latest research available from Lumia Health. And our webinar today is called The New Device for POTS and Dysautonomia, Tracking Blood Flow to the Head with Lumia. And in today's program, we are featuring Dr. Amanda Miller, myself, Shivani Ugrin, and Daniel Ewok Lee. It is August the 1st, 2024. And let me just check to see if we have our attendees getting in just fine. All right, wonderful. All right. I think we have critical mass. So hello, Daniel Lee.
Hey.
Welcome. Thank you for joining us today. And hello, Dr. Amanda Miller.
Hi.
Hi, thank you for joining us today. Okay, so let's go ahead and get started. Dr. Miller, would you please tell us about yourself?
Yeah, I'm Dr. Amanda Miller. I have a PhD in neuroscience, and I've been consulting for Lumia Health since January this year. I also have POTS-EDS, some autoimmune stuff going on, maybe more.
Good to know. Thank you. We're so glad you could join us for today's presentation. I'm Shivani Ugrin. I am heading up the marketing, community, and communications at Lumia Health, and I'm also a zebra with Trifecta. So I have POTS, HEDS, mast cell, as well as long COVID, and a number of conditions that make today's content extremely relevant for me personally. So we are, I know, Dr. Miller, you and I are both highly invested in the information we're about to share. And last but not least, Daniel, would you please introduce yourself?
Yeah. Hey, everybody. My name is Daniel, one of the founders of Lumia, and I do not have any of the trifecta or any of the conditions. I think my initial connection has been that my father has very severe orthostatic hypotension, and Shivani has lovingly given me the diagnosis of severe startitis. So that's what I got to fit in. Go ahead, Shivani.
Okay, well, Dr. Miller, I'd love to start with you, please.
So we did this study at the Dysautonomia International Conference in 2023. We enrolled people who were self-diagnosed as having a type of dysautonomia, mostly POTS, but we accepted people with orthostatic hypotension or other diagnoses. And then healthy control subjects were enrolled after that to age and gender match the patients who were at the Dysautonomia conference and did this study. And we had people lie flat for 5 minutes, and then they reported the severity of their symptoms. These could be any symptoms from, palpitations, fatigue, lightheadedness, from 0 to 5 each minute while they were lying down and then standing for 5 minutes. We kept the symptoms broad, and then we analyzed the data from that conference, and we were able to show it at that conference, and we'll show you some of it today.
Amazing. All right, here you go.
Yeah, so what's interesting about this study, for a lot of research studies, the researchers have patients go off of all their medications, sometimes for weeks or months before the study. They control their diet. But we did a real world study here. We wanted people to be taking whatever treatments they were, wearing compression if that's what they do normally, drinking their salt, and eating their salt, sometimes drinking their salt too, and their fluids. So we had people on several different interventions, and we wanted to see if there was any change in the blood flow to the head despite taking these different treatments that people are normally on for dysautonomia.
I'm gonna actually just, sorry, I was supposed to give a little bit of a preamble for
I thought so.
for Dr. Miller, so sorry, Amanda. But I think just to give a little bit of some context here. So today's presentation will be covering actually just some data, some new data of some of the studies we've been running. So that's what we immediately started diving into. But we'll also be sharing some just kind of, I mean, Shivani's actually going to be sharing some of her personal data as someone with POTS who has been using it now for many months, and just kind of showing some of the novel new insights that we can see and how it might be helpful for self-management. So that's kind of the structure of today's webinar. And that's what we're going to be starting right off with some data as Amanda has already started to dive into. Sorry again, Amanda.
Yeah, no, that's good to give some context.
Yep.
Yeah, so that's what we'll be showing today. So first, the symptoms we saw in those participants at the Dysautonomia International Conference were basically in the orthostatic intolerant participants who are in the red line, the health controls are in the blue line. So basically, when people with orthostatic intolerance stand up, they have an increase in symptoms over time. But the healthy controls have this initial rise in symptoms, but they're pretty mild, and then it dips back down after they've stood up for a while. Can you click? Yes, thank you. So then we measure a flow index with the Lumia device. And what we see is that flow drops almost 3 times as much in the orthostatic intolerance participants as it does in the healthy controls. There's about a 6% drop in the healthy controls and 17 to 18% in the dysautonomia participants. So that's quite a significant drop, and that's consistent with some other studies that we'll talk about. Okay. So then we also looked at a blood pressure index, and there wasn't really a change in blood pressure in either group during the laying down or standing. And then what was really interesting in this study is that most of these participants had POTS, but they didn't have a significant change in heart rate. It was about 15 beats per minute on average in the orthostatic intolerant participants, but it was only about 11% change from laying down to standing in the healthy controls. So this isn't meeting the 30 beat per minute criteria that we usually define POTS by, and this is probably because people are on their treatments and optimizing their care. So even despite a normal change in heart rate and blood pressure, we're still seeing this drop in blood flow to the head. So we also did a correlation between the symptom scores and heart rate. There was no correlation. So despite how people's heart rate changed, their symptoms were not related to that. Then we also did that with the pressure index. Again, not really an association. So we don't think blood pressure is really accounting for symptoms. But when we look at the flow index compared to the orthostatic symptom severity from 0 to 5, that is significantly correlated with the symptoms. So we think that the blood flow to the head index that we're measuring with Lumia is indicative of symptoms people are experiencing with dysautonomia.
Awesome. So I think this is actually pretty consistent with some of the prior literature. This is, for some it might be new, but for people that have been following the science for looking at cerebral blood flow, there have been many studies from many reputable labs that have been using different techniques such as ultrasound to measure if the flow to your head is changing when you're laying down and then standing up. So what Shivani is now sharing, this is actually Dr. Peter Novak over at HMS and Brigham, where he has actually been one of the earliest pioneers of doing a lot of transcranial Doppler ultrasound, using ultrasound to measure blood flowing to your head, and tilting a bunch of patients that have orthostatic symptoms, and then seeing what this data analysis is showing is actually what percentage of the people that are complaining of orthostatic symptoms, like what buckets do they fall into? And if we actually look at the data he shared, 27% have orthostatic hypotension, which is a dominant diagnosis. 23% had POTS, which is surprisingly not as much as I was thinking. But there's one of the almost largest groups was a group of patients that had a drop in cerebral blood flow, but their heart rate and blood pressure were normal. It did not cross the POTS criteria, or the blood pressure did not drop below the orthostatic hypotension criteria. And so it just kind of shows like there's actually a lot of patients that if you're not measuring cerebral blood flow, they're being told nothing is objectively wrong with you, but you have to be measuring the right thing. So this is just one study. If you go to the next slide, another group of pioneers in this field have been Dr. Visser and Van Kampen over in the Netherlands at Stichting Cardiozorg, as well as Peter Rowe at Johns Hopkins. But they have been doing on many, many patients as well. Another technique to measure cerebral blood flow, where they measure using the carotid and the vertebral arteries and measure actually true cerebral blood flow. And what they see actually, this was in a population that their primary inclusion was chronic fatigue syndrome, ME/CFS, but they had 28% of them had POTS, 14% had orthostatic hypotension, but a majority, 58%, actually had normal heart rate, normal blood pressure, but they had abnormal cerebral blood flow drop. And so that's where it's like, it's kind of what Amanda just shared, and like everything looked fine. Symptoms, people weren't fine. Symptoms were high. Heart rate and blood pressure looked fine, but the flow was not fine. And so it's just kind of reiterating. So what we're showing is very similar to what the literature has already shown on thousands of patients at multiple sites. You can go to the next slide.
Oh, that's me. But Daniel, no matter how many times I see this literature, I've read it before, I've seen this slide before, it always blows me away, because I have to think about how many people are out there and they're either completely undiagnosed or they've been through a laborious diagnostic process with lots of expensive testing, and yet they were told that there was nothing wrong with them. Just because so many people are affected. I know as a person with POTS, I can't wrap my mind around how we can be so strongly affected and yet still be underappreciated that this is going on. Even if our heart rate and blood pressure are being well managed with the current standard of care, we can still be highly symptomatic. So these are some of the statistics I found on Dysautonomia International's website, that physicians who are experts in POTS are comparing our functional impairment to people with COPD or congestive heart failure, that about a quarter of the people who even got a POTS diagnosis are disabled and unable to work. We don't know those statistics for the people who've been told they were normal but are having this problem. Researchers found that the quality of life in POTS patients like me can be comparable to people on dialysis for kidney failure. And so it's generally understood, the demographics are hard to capture, but people with other forms of dysautonomia who were able to get a diagnosis have similar rates of impact to their quality of life. And just really what blows me away is, you've shown us this literature that there's probably 15 years now of data that show that the cerebral blood flow is dropping in people who have the symptoms of orthostatic intolerance. But too often, my experience, and I imagine the experience of many people listening to this webinar right now, are that our doctors are sometimes unaware. We find out that our treatments aren't targeting any of that. The treatments are often targeting secondary symptoms like the heart rate response or the adrenaline response with meds like clonidine. So I'm just blown away. Like, how did we get to this point where it's 2024? There's a stack of literature showing that these changes in blood flow are happening. And yet my medications that I can have my doctors prescribe have never really been checked for efficacy of this problem.
So I can answer that. So, this is kind of what we've been doing now. We've started the company now over 4 years ago, and we've been trying to look at different ways to try to measure what was happening. And these two methods that are shown here, Trans-Cranial Doppler Ultrasound and extracranial ultrasound, they are the pioneering ways to actually measure that something is different in the flow to your brain. Now, the challenge though is the number of labs that actually use this technology. There's less than 10 that I'm aware of in the world. I know many have tried, but there has been some challenges of having people that are trained to do it properly. There's actually been many people that have tried to reproduce some of the transcranial Doppler ultrasound literature, but they also, due to differences in ultrasound machines and skill set, it's highly specialized, and they've had troubles with reproducibility due to some of these challenges. And we have as well. We actually have an ultrasound now, and we've tried to reproduce very, very similar studies, and it's just very hard to get a good signal through laying down and standing up. So that there's very few that are actually using in routine tilt table testing. So most people on this call, if you've been on a tilt table test, you probably have not received a transcranial Doppler ultrasound, unless you're at Peter Novak's lab in Brigham and a handful of others around the world. Now, this is also kind of limited in if many have probably experienced a longer delay now, especially trying to schedule a tilt table test. But it is a very involved process. You have multiple staff members that are here watching. They have to staff and be ready for you to pass out on a table. So it is a bigger undertaking. And so there's just a lower volume that you can actually have patients go through this. And it is just kind of expensive. It is hard to do. It's very specialized. So it's just, it is not really a scalable technology. I'm not saying like this is necessary, and it's still a very important technology for this to have even been identified. So for the pioneers like Dr. Novak and Dr. Visser Van Kampen, like their work has been instrumental to kind of catalyzing this, but it's just hard to scale this for the millions and millions of people that are having these issues. And so that's where what we're trying to do comes in. If you could go to the next slide, Shivani. That's why we're building Lumia. So Lumia is a tiny in-ear device. You can see it, and actually this is a little bit an older version, but it continuously measures blood flow to your head. So it's looking in the upper ear. It measures a shallow ear artery, which is a branch of the external carotid artery. So we're not actually measuring direct internal carotid. We are measuring off the external carotid artery, but that artery there, because it's so shallow, we can get a very nice clean arterial signal. Next slide. Yeah, and kind of what we're trying to build, I think the closest analog for what we're trying to do for people with orthostatic issues where blood flow to the head is compromised. We're trying to build a continuous glucose monitor-like experience so you can better self-manage what you're doing, what's going on your body. Next slide, please. Okay, so I'll get into a little bit of the underlying, how this actually works. We call it actually blood flow to the head very intentionally. So we're not claiming cerebral blood flow, which is what the ultrasound literature is measuring, because we're measuring it off the external carotid artery. So technically the external carotid artery feeds kind of your ear, your face, things outside of your skull. And the internal carotid artery is the one that goes actually into the inside of your skull and feeds 70% of the blood flow to your brain. So we aren't measuring directly cerebral blood flow. We call it blood flow to the head. That holds though in orthostatic situations, because orthostasis is upon standing. So when you stand up, gravity pulls blood into your legs, and normally your legs are supposed to squeeze that blood back up, but for orthostatic people, that loop is not exactly working properly. And so that causes a drop in preload. That's what doctors call if you don't have enough blood filling the heart. And because of that, if not enough blood is filling the heart before it pumps, when the heart pumps, it's going to have a reduced amount of blood that leaves the heart. That's what doctors call stroke volume. So each pump has less blood volume, and that's what's causing the reduced blood flow to your brain. It's the fact that your heart is not pumping enough blood out towards your head. And because of that reason, both the external carotid artery and the internal carotid artery are both affected by that reduction. And that's how we can use the external to actually infer what's going on internally for orthostatic people. So next slide. So this is actually the raw Lumia waveform, and the top is actually during a Johns Hopkins tilt table test where a patient was not symptomatic in the top chart. They're fine, they're laying down. When they're tilted up, this patient did pass out, but a minute before they passed out, they're clearly very symptomatic, and you can see the waveform changes quite dramatically. It's a much more pulsatile, a much more spurty waveform. It's much more shallow because the heart is, I call it dry heaving, but it's taking very short little spurt pumps rather than nice long pulse. So that's kind of how the technology works. But we could go to the next slide.
Yeah, well, and I can jump in and just share with everyone at home what this looks like, at least from the Lumia device. So I've been wearing a Lumia prototype since starting in November, on and off, with different models of prototypes. And one of the first things we did actually was a whole bunch of stand testing, which I think anyone with an orthostatic condition, if you have POTS, if you have OH or syncope, you can understand that a lot can happen in 5 minutes. And at first I had protested that we should be doing 10-minute stand tests because that tends to be the standard. But as I quickly discovered, we can actually see a lot in a stand test. So the graph on the left is my heart rate. And so you can kind of see my heart rate was at a baseline as I was working at a desk at Lumia headquarters, and had a little bit of a heart rate rise as I was walking to the lab space. then it settles back down to my resting or close to my resting as I was lying down for 5 minutes. And so you can see my heart rate smooths out at a nice, comfortable low. And then in the shaded blue region with the standing person icon, you can see I stood up. And as I stood for those 5 minutes, my heart rate was rising and rising and rising, as it does in a person like me that has POTS. So you can see that heart rate spike during a 5-minute active stand test. And then after the 5 minutes, thank goodness, I was permitted to lie back down, and you can see almost near instant recovery in my heart rate. So this is all very classic for POTS, and this is something that most of us can measure with a good quality heart rate monitor device if it is set to a continuous mode. But on the right is something that we can't do at home, and this is the Lumia Flow Index. So you can see I actually had pretty good flow as I was working at my desk, and as I walked to the lab, which is the first blue shaded region, you can see that my flow index suddenly began to oscillate a bit up and down. I removed my compression and lied down flat. And something very interesting about that period, this is the little white band around that 1610 time stamp. That was during the lying down phase. And I was really a bit surprised to see that during this lying down phase, because I had taken off my compression, we're actually seeing my flow start to drain out without that compression on, which to me, this was quite shocking. One of the first major shockers of getting to test a Lumia device was that even during a lying down phase, I could be draining out and losing my flow. It's very shocking to me. And then you can see in the blue shaded region, the 5-minute active stand. And you can see there is an almost instantaneous plummet in my Lumia flow index. This absolutely mapped to my horrible symptoms. I was getting all the symptoms that I would typically get during a standing test. So for me, that's red flushing, it's suddenly feeling hot, it's headache, instant headache, lightheadedness, dizzy, inability to focus my vision, nausea, all the things. And again, wonderfully, at 5 minutes, they told me I could lie down. And so lying down again, you see my flow impressively shoots right back up, and my symptoms began to subside. So it was really shocking, even just in 5 minutes, how strong a reaction we can see in my own head. And this is in a person, like I am pretty functional, right? I have been through CHOP protocol. I did CHOP protocol, which is an exercise rehab program for POTS. I did it slowly over 2 years and have been continuing to train. I'm a person that is, now able, after having bedbound time periods, I'm now able to work full time. So I'm a pretty functional person. And it was shocking to me to see my flow index was 14 when I was working at a desk, and crashes as low as a 6.5 within the 3 minutes of standing. It looks like the worst of it was in the initial few minutes. And then that it can so swiftly return to an even better than baseline level of flow index during that lying down recovery. So this was one of my first stand tests with a Lumia device. There was so much, even though I'd read the literature, I had never had any sort of CBF testing before. So I was just assuming that this problem would affect me, but I just remember how blown away I was getting to see this. But, let me ask the PhD in the room, Amanda, like Daniel was telling us about these other methods of measuring cerebral blood flow, like transcranial Doppler or the carotid ultrasound. So can you share with me, like, what are we looking at here? Is this actually good information when you compare this with laboratory style instruments? How good is this?
Mm-hmm. Yeah, so how good is this was exactly my question when I first heard about Lumia. So I've been studying brain blood flow for about 12 years. Actually, the first lab I worked in that was doing POTS research was Julian Stewart, and he was one of the pioneers that was using transcranial ultrasound to measure blood flow to the brain in POTS. And I know that there's lots of challenges to using TCD. I use it, but I know that most clinicians aren't trained and don't have time or the funds to get an ultrasound device and use it regularly. So I was wondering, how good is the Lumia compared to the 20 years of literature we have on POTS? And the answer is, it's pretty good. At least in my opinion. If you look at these waveforms, the light blue line is the TCD brain blood flow, and the black line, or the navy blue, I'm not sure, it's hard for me to tell, but that is the Lumia blood flow index. So you can see they track pretty similarly. Those waveforms are almost on top of each other, and they have the same trends throughout the heart rate cycle. Next slide. So if we compare the transcranial Doppler ultrasound to the Lumia device in different positions, we also see that they track pretty similarly, and the time course is really similar. So this is looking at the flow index with both devices, and our faces are over which one is which. Oh, the TCD one is in the light blue, and the Lumia is in the brown or orange. I'm bad with colors today. Okay, so you can see from we had people do several different orthostatic positions, lying down, standing up, sitting, marching in place, and then had them do different breathing manipulations as well. So Valsalva maneuver, deep breathing, hyperventilation. So we want to see what happens to the blood flow with both of these devices in these different posture and breathing conditions. And you can see there's a drop from lying to standing, but what's important here is that the Lumia flow index really mirrors what we see in TCD. But the problem with the TCD is that we can't use that in everyday life. It's really only used in a lab setting. So I think this is going to be a great tool to be able to track what happens under different conditions in daily life.
All right, thank you.
Okay, sorry, just the next slide. So we actually did a correlation between the flow time with the Lumia device to carotid flow time with ultrasound. So this is a calculation we can use with both of these devices. And we did a correlation between all the pooled data points from 18 participants that wore the devices at the same time. So for those who aren't familiar with correlations, a moderate correlation is usually about 0.4 or higher. A really strong correlation would be like 0.8, and a perfect correlation, which means the data is exactly the same, would be 1. So our correlation here with the flow time is 0.9, which as a scientist, that's almost unheard of. Like, that doesn't usually happen. So these data points from the different devices are really similar and really strongly correlated with each other.
Thank you, Dr. Miller. It's so exciting to know that, because I mean, I would take anything I could get at this point that gives me even just a directional indication, but to know how strong it really is exciting. So I'm about to share some graphs that we've been generating out of my own personal data. So, you know, I'm happy to share my brain blood flow disease with all of you, because I know that we need to really change what's happening with how these conditions are understood and managed. So I'm about to share with you some very personal information about what's really happening in my head. And it actually took a lot of emotional processing for me at first to kind of come to grips with what I was seeing. But at the same time, it's become a really empowering journey. So before I jump into those graphs, I just want to share with you a few, you know, a side note here, not even a side note, but an important note that what these graphs are coming out of are the behind the ear research version of the Lumia technology. And at the end, before we do Q&A, I can actually hold up the one I have here. So this one was built for in-lab use. It does have a very large battery and memory, and so we can capture extremely high quality data. but it's this unit that's shown on the left here, the purple one. It's not wearable for sleep or showers, so there's certain types of testing I didn't get to do. And it's not tied to any sort of mobile app or graphs that I myself could generate. So during the times I've been wearing this version, I've had to log all my activities and timestamps, my little missions in a spreadsheet. And our research head has been generating graphs for me and in sort of a blinded fashion. What we are actually going to be shipping, and we will begin to release our beta units in the coming several weeks, will be our fully in-ear consumer version of Lumia. So this would be the one that's for take-home use. It is absolutely tiny. So the core of the device is about the size of an espresso bean. So that means it is working off of intermittent data capture, very similar to a continuous glucose monitor that can capture a reading every few minutes. And I know Daniel and the team are working very hard on being able to have like specific options to trigger close recording based on stands or based on the person wearing it deciding to initiate closer recording when they feel symptoms. And so that would enable closer readings. And this style of device will be wearable during sleep, showers, and I'm actually excited. Pretty soon, I should be able to start sharing my graph stories using that device in these new contexts. So just to be clear, all the graphs I'm about to share in this presentation are from the first device.
And actually, I just if I could just clarify really quick, when Shivani means close recording, they have the same kind of sensor. It's just that the behind the ear version is measuring every single like heartbeat constantly, whereas the one on the right and the one that's going to share that we're shipping initially is not doing that all the time. We're measuring once every 5 minutes, and then we also trigger. So it's like only like 10 seconds every 5 minutes, and so you have a lot less granularity, but it's the same data. And so that's just a little bit more clarification on what that means. Like they have the same kind of quality data, it's just that the sampling rate or how often we are sampling the data is different. So
great. Thank you for clarifying that, Daniel. So one of the first adventures, I believe this was actually on my first day at Lumia headquarters back when they were called Stat Health. I walked over with the team to the local Dunkin'. Fun fact that the Lumia Health team is powered primarily on sugar and caffeine supplied by Dunkin' because of that close proximity is very convenient. So I had a apple fritter in the name of science. Now I know for myself, I normally react very strongly to sugar consumption. So I was expecting that we would be able to see something, and sure enough, we did. So within about 10 minutes of eating the donut, you can actually see the top graph in green with the Dunkin' label is my Lumia flow index. And you can see how I was hovering around a 10 before consuming the donut. And as the symptoms onset, you see a notable dip in my flow index. So I had very strong symptoms onset with tachycardia. So in the bottom graph, you can see my tachycardia went over 110, even though I was sitting down. I had visible hand tremor that the whole team was able to observe in a very reactive, fun person. And I was feeling dizzy, feeling adrenaline. But what's interesting is I did have a pretty rapid resolution of the symptoms from this sugar crash that really everything was kind of back to normal 35, 45 minutes. And just for context, I have no history of any unusual glucose results. My A1C and my fasting glucose measurements have always been perfectly normal. I do not have a diagnosis of diabetes or reactive hypoglycemia. And what's been interesting is there have been a couple recent research papers about excess release of GIP in patients diagnosed with POTS. And GIP is a vasodilatory hormone. So we don't know exactly if that's what happened here or if I had some other sort of abnormal glucose handling reaction. But for those of you who have these conditions, you might notice whether or not sugar drives any symptoms for you, and hopefully someday be able to see any flow changes for yourself, because I know we are all different, and what affects me the most might be a little bit different in how it affects someone else. But this was a really fun example in an area that's really quite cutting edge for POTS research. And another example, I think you might be able to relate to, that shopping can be very hard for us. So there was a particular day wearing this device that I needed to do some shopping for clothes. And I knew I was going to go shopping. So I had my medication, which was Northera. I had a keto morning with caffeine helps me vasoconstrict and manage my flow. So I had keto coffee. I was wearing very strong compression from my midfoot all the way up to high ribs. I was also wearing an abdominal binder. I often wear heels if I'm going to be on my feet for a while, because this can increase the venous return and, using my calf muscles. And I had had a liter of lactated Ringer's IV infusion the day before. So I was not hypovolemic as far as we know. And of course, sodium loaded, right? So we can see that I started off my shopping expedition with very strong flow, anywhere between 12 and 14. And as I did the shopping, you can see there were several plummets in my flow. And, looking back, I had done various counter maneuvers, right? I had done like butt kicks and knee raises and calf raises. For a minute, I had sat down in the shoe department. Those counter measures do seem to boost my flow right back up, but the effect is really fleeting. And it was somewhere around 2 o'clock, which was 1400. You can see my flow was in that 8-9 range, where I suddenly had a crisis. But I think we can all see that my sudden crisis was not at all sudden. It actually had this long, slow, hour-long prelude. And this is where, where the device is currently recording every 5 minutes, and possibly more frequently once we activate a few more features. We don't necessarily need the closest recording to know that we are approaching a danger zone, so to speak, that we are approaching states of low flow and that we're in a decline. Because at least for me, even with all my treatments, the gravity plus the time was much stronger than all of these interventions. So, I did manage to get out of there. I was texting our research head like, hey, let's make sure this is all time-stamped, because I think we're going to see something. And sure enough, a few days later, when we pulled the graphs down from the data platform, we could see. So again, during this sort of sudden crisis, I had all the classic symptoms. I was beet red, I had tachycardia, I was nauseous, I was overheated. My blood pressure was extremely high. I have orthostatic hypertension, which is the BP rising type of hyperPOTS, and a headache and a sense of doom. But what I love about this is it really shows that, even with all the best treatments, even with the best medical care and being adherent to doing all the right things, still don't get to go shopping like a typical person would. So along the way, I'm not just learning about what is dropping my flow or crashing it. We've seen a rapid crash with the stand test, and we saw a slow drain with the shopping. But I'm also learning how to restore my flow. And one of the most powerful things any of us can do, it's free. You just got to find a cot or a couch or a bed, or get, if you can, get down to the floor and get your feet elevated. So this is a example. In the top graph is my Lumia flow index, and in the bottom graph is my heart. I did a brief stand without my compression on and predictably crashed my flow. It had been 10 and crashed down to 6.5 or 7. And I immediately hopped over to the bed, put my legs up the wall, and we can see that over a 10-minute leg raise, my flow increase was immediate. And not only immediate to baseline, immediately back up to that 10 within seconds, right? But even over the 10 minutes, I was continuing to improve and improve and improve my flow. And then when I sat up briefly, it dropped a little bit back down to baseline, back to the 10. So even sitting up in someone like me, even sitting up without my compression on can cause a drop. And that was just like sitting on the bed trying to reach for my compression. And so, how long should I hold a flow restore pose, like legs up the wall, or what they call a passive leg raise? And how long is optimal for you? There's kind of, we can go based off of our symptoms. But for me, yes, I already knew all of this on paper, but to see my own graphs and to see how strongly my head blood flow responds to these physical maneuvers, I am getting much, much more willing to stop what I'm doing, to step out of whatever my situation and say, no, I'm gonna stop in the middle of this conference and I'm gonna hop on that cot, I'm gonna put my feet up the wall, which I did a few times at our recent EDS conference. And I'm gonna be unapologetic about that. So I now have a dysautonomia wallet card that I got from Dysautonomia International. And if I need to, in any public place, get my legs up the wall, I'm gonna do it. And they can arrest me if they want. In the bottom graph, you can see my heart rate was predictably high during the stand and dropped nice and low during the leg raise. All right, I think this might be the last graph, and this is again learning what raises my flow, what lifts my flow. For me, a very powerful tool is my vasoconstrictors, and I find that this works for both the humble caffeine, as long as it's sugar-free for me, but also I have a medication that I am very grateful for. It's called Northera. The generic is called droxidopa. And it is not covered by my insurance, but that's okay. There are affordable sources now. And, you know, again, this is what is for me. I'm not recommending this medication for anyone else, but certainly if you have certain types of medical conditions getting diagnosed, it's something that you could have a conversation with your doctor. But I do want to share. So the top graph is my Lumia Flow Index in green. And, you know, you can see like I started off at, I don't know, a 12 with my baseline. I had a bit of a drop after a carbs and high histamine lunch. It was some sort of wonderful, tasty stir fry with high histamine sauces. And then at some point, you know, feeling those symptoms, feeling that drop from lunch, I took my Northera. And just as the prescription insert describes, the effect comes on in about a half an hour and lasts for about 3.5 hours. It really stabilized my flow. And you can see that there was also a modest reduction in my heart rates as well. And this was on top of compression, so kind of a fully treated day. And so for me, you know, Northera is really my game changer. It's one that helps me a lot. And what works for you is going to be, you know, something to discuss with your doctor. But I know that right now what we're doing with Lumia, it's not a medical device, right? So I'm wondering, Daniel, can you explain for us how we can use Lumia in a way that is not a medical device until we could someday become that?
Yep. So this is a very important and there's a thing to understand at the moment is very similar to current wearables such as like Apple Watch, Fitbit, Whoop, Aura, all these devices that are used for kind of self-managing and learning about your body. That's kind of, there's a carve out for that called like a wellness device that the FDA says is you're allowed to kind of help even people with chronic conditions or various like diagnosed conditions for self-management purposes to provide data for that. So that is what we can do. It's and as Shivani has shared throughout the talk today, there's many things that she can learn about triggers, about her interventions, about how to like apply and know when to slow down. And so that's kind of the self-management use case. It's very important that it's not used by doctors at the moment because it has not been evaluated by the FDA. It has not, it can't, we currently and very intentionally are not trying to present the flow index in a way that can be compared against existing diagnostic criteria. So it's not interpretable yet to physicians, but very intentionally because we're not allowed to be used in that way for now. That though we do know that is what we need to do. It's just a very long path. And so the next, if you could click, Shivani. So we are going towards the path of becoming FDA-approved diagnostic because as you saw earlier, so many people are being told nothing's wrong with you because they're measuring the wrong thing. And so that is kind of our long goal. And we have been doing a lot of the work, all of this clinical trial and testing work and working with top hospitals and generating this evidence. That's in support of having the FDA review that and that this become the new kind of paradigm for diagnosing and managing these conditions. But that's not where we are yet. We're publishing, but we haven't gone through the full process yet, so we cannot be used in that way. But that is kind of our goal. And we hope, like, can we just be, instead of a tilt table, or in lieu of, not fully replacing tilt tables, because there's a place for tilt table testing, but there's a lot of situations where where a tilt table test is not necessary. But if we could just do an orthostatic vitals test at home, that you have your Lumia device and you could run a stand test and send those results to your doctor, and that could actually be used in a diagnostic capability. That is kind of our goal, our longer term goal, and we think we can really help catalyze the whole medicine and pharma and so many different people to start focusing on the right thing to be optimizing. But that is still an ongoing process. We're currently going through a pre-sub planning, and so there's just a long kind of procedural process for that. So that is where we are at the moment. We are self-management. We are not yet a medical device, although that is our aspiration. Next slide. So what's next? Many of I actually see a lot of beta members here. So hey beta, that's kind of our near-term focus right now. This month is we're just all the team is all out and just getting the products ready to be shipped to our beta members, so people can start to be doing very similar things to what Shivani has shared, and so that's our very near-term goal. But in kind of parallel with that, we are trying to continue to publish the science for the long-term medical diagnostic use case and just bringing awareness. But you got to really start measuring CBF, or at least a correlate to CBF. Start measuring flow and not just heart rate and blood pressure, these secondary metrics that often mislead. And so we have various data sets that we are looking at publishing in a proper peer-reviewed journals. And that's what Dr. Miller is helping us with. She has a long publishing history, so she's we do the data collection analysis, but getting it into a journal and doing that process is where Dr. Miller is definitely the expert. And we actually just recently, I think it was a couple of weeks ago now, we were at the Ehlers-Danlos Society to do very similar to what we did at the Dysautonomia International Conference. We had 50 people stand. I think we said it was stand up for EDS and stand for 5-minute window. And
stand up for zebras.
Oh, stand up for zebras. My bad.
Stand up for zebras.
So we did actually, we wanted to show this in EDS as well, EDS and HSD. And so that is another data set that we're publishing. It's just that we're seeing so many conditions probably just have flow drops that are really driving a lot of symptomology. And so we're now trying to show that in more populations. And also we have received, fortunately, some government grants for various different types of applications. I think the government is seeing, and various orgs are seeing the promise of the data that, and just the raw data that we can capture. And so they are looking at many different use cases for applying that to various government use cases. So that is another kind of work stream that the company is supporting. Next slide. You could speak to these, Shivani.
Yeah, I can. And I can actually show you these on camera once we get to the end of the slides here. But the basic physical components of the Lumia program are the earpiece itself, which is tiny. It's about the size of an espresso bean, and we have 18 different jacket sizes to customize the fit for a wide variety of adult ears. And even with the jacket on, it weighs less than 1 gram. So just compared to any other wearable device that could do anything like this, there's just no comparison. And it is shocking how small, Daniel, that you and the engineering team have managed to turn, micro miniaturize all the components to be able to do what you're doing. And it's still shocking to me. And I've been here since November. The next piece is the light station. This is where your Lumia device can rest and recharge like we all need to. And it's the data hub and sync manager for your Lumia. And I'll be able to show you that in just a few moments. And then lastly, the carry case. And this is just a safe place to hold your Lumia if you need to take it out. For example, if I'm going to go get my hair shampooed and cut at the hair salon, I don't want them to wash my Lumia down their sink. And so I'm going to put my Lumia inside the carry case. And the carry case is specially designed with a little window lens so that even if I'm not near my charging base station, I can just stick my Lumia in its carry case under a desk lamp or in a ray of light in the window, and it can actually be getting a great charge off of that solar panel. So before we do Q&A, and it looks like we'll have we'll be able to do about 15 minutes of Q&A. I want to give you some rapid response answers, and this would help us to just take care of some of the really standard top 20 or so questions that do get asked about Lumia. So let me just zoom through these. Lumia is for the left ear only. It cannot work in the right ear. It only goes on the left. It is currently designed for adults only. It is currently available in the 50 United States only. Lumia is currently only available to sync with iPhone and is not available for Android users at this time. Long story. We are HSA and FSA eligible at the moment. We are not actively selling, so I'll get to that. But as soon as we reopen orders, you would be able to potentially, based on your program's rules and requirements, be able to use those funds. You can wear it in the shower. You can wear it sleeping. It is solar charging. Our first 500 beta units will be shipping soon. In a sauna, a lot of people are using different contrast heat therapies to try to, advance their wellness. So the device would turn itself off over any temperature like 140 up just to protect itself. For people who are doing cryotherapy, the device will turn itself off below 30 F. This is not a treatment. It is not a vagus nerve stimulator. It's not actively doing anything to you. It is simply a tracker that can help us self-manage our symptoms by better understanding what is raising my flow and what is crashing it. This is not a wellness device. It is for this is not a medical device. This is for wellness use only for now. Like Daniel said previously, we are working on that long and difficult road to FDA review and approval. The device is compatible with most hearing aid styles. There are some specific styles of hearing aid that need to occupy the entire auricular space, the kind that are molded to sort of fill that whole area. In those cases, we do not know yet, but some of our community members have shared with us that they plan to attempt a remolding. We do not know yet how that's going to work. So stay tuned on that. For piercings, obviously the piercings are not the problem, but the jewelry for a rook, daith, or conch piercing might interfere with where Lumia needs to be in that left ear. And so if removing that jewelry would be a problem for you, please consider very carefully before ordering. It is compatible with most hearing protection devices, most earbuds, AirPods, loop silencers, and similar devices. It actually works fine with my over-the-ear running music earbuds, so was really happy about that. You're probably wondering how much is it? So again, we are not allowing orders right now, but as soon as we do, it will be $379 for the initiation kit, which includes your Lumia wearable device, the light station where it can sync and charge, and the carry case. Plus there is a membership. So membership is required. The device will not function without it. So Lumia is a whole comprehensive program with, support for our members, with a special warranty on all the components. That continuing membership indicates things like hardware upgrades as Daniel and the engineers continue to evolve the hardware and the technology for what Lumia can do. So it is a little bit more like the continuous glucose monitoring programs, but unlike those programs are hundreds of dollars a month usually. Ours is going to range from $13.99 up to $19.99 a month, depending on how long of a term you do purchase. All of those details would be very clearly stated by the time we actually open orders. Like I said, we're not accepting orders at the moment. There is a financial assistance program available. Seats are very limited. We're actually in an open application period right now. So that is going to be ongoing. And our patient advisor council administers the selection process. We are sold out for units that would be shipping in 2024. Thankfully, the support of this community has just been incredible. So we have a great number of pre-orders that we need to fulfill. So we have temporarily paused orders, and I'm hoping we can get that website open for new orders in a couple months. And those would be for devices we would begin shipping in early 2025. We did change the company name, so Stat Health is now Lumia, but all the team is the same. All the co-founders are the same. I'm still here. We're all still here. Lumia's notifications, which we call nudges, will be intermittent notifications and not real-time alerts. And lastly, that, who is it for? It's for people who, at least currently, have a diagnosis of one of the conditions associated with drops in blood flow to the head and orthostatic symptoms. So right now, we are not trying to promote this device for general wellness or general longevity. We really want to focus device availability to people who have a validated medical condition that we believe this is going to be incredibly useful for you. And then in the future would potentially open this up for people in more different types of situations. Okay, so Q&A, sorry to have to run through that, but I think it'll save us a lot of time in the Q&A. Daniel, are you already looking at the questions?
I literally did about 10 seconds ago, so I totally forgot
10
that I could
seconds
see
ago,
this.
I must be that you were just enraptured by my well, because I was reading that, I have not looked at the Q&A, so do
So
we have...
I'll start from the middle and go down if you want to start from the top and go down, but I'll kind of like skim through a few of these.
I'm in the middle.
Well,
I'm looking
okay.
at the middle going down.
Okay. So will the device have an app, and will that app allow us to record our behaviors in order to correlate to the blood flow data? Absolutely. So there is a mobile app in the that it connects to on iPhone only at the moment, but we can tag different moments throughout the day. Not all these features are going to be available at the outset for beta, but by the time that other people are ordering it, you'll be able to tag various moments. You'll be able to also like log various interventions you're doing, your medications, and try to understand how some of these factors throughout your life, how these are affecting your blood flow data.
So I see a good question. Do you plan to collaborate with academic research groups who are working on clinical trials for treatments for dysautonomia and POTS? Absolutely. I'm one of those people who is waiting to. So we're building, like the Lumia team is building devices for that, but we have a long list of people to collaborate with. And
speaking of those research devices, here they are. So this is our research platform device. So it fits over the ear, and then this cute little glow thing fits in the Nook space. So I got to spend a lot of time with this guy.
Yeah, so that's definitely the space I think Daniel probably wants to jump in and stop me about this, but Lumia can be extremely helpful for. I mean, that's why I wanted to join the team, because I think it's a missing marker that isn't measured in a lot of POTS studies. So I think it'll be a more accessible way to track blood flow to the brain or to the head by using this device in research studies as an outcome.
Yep. And we are talking to many and then looking at different ways to support both on the diagnostic and on the therapeutic side. There fortunately is a little bit more of an openness now to trying to see something beyond just heart rate to see that something's wrong, because they're clearly seeing a lot of people that are symptomatic are totally being missed and excluded. So there's a couple of questions around how does the Lumia index compare to the centimeter per second measurements from transcranial Doppler? This is one of those examples where transcranial Doppler has different kinds of diagnostic criteria that can be from TCD measurements, and we actually cannot be mapped back to that. So it's more of a relative index of how it's going up or down that we have shown correlates with TCD going up or down, but it's not actually, we actually, you can't back calculate to that, and it can't be used in that way. So, but in general, higher is higher, lower is lower. Relative changes are roughly about correct, but we can't map it to a 50 centimeter per second that could be correlated to many other things that you can diagnose off of that.
Daniel, there's an interesting one here. There was one of our attendees mentioned they did get transcranial Doppler during their tilt, and on their tilt, they actually had different activity in the hemispheres, that they had a major drop on the left, but then the right would be all right, and then the right would drop. What can you say about what Lumia is able to see from its site in the left ear?
So that's actually why we have to go on the left ear alone and not just the right ear, because your body's not symmetric. Off of your heart, there's an aorta that climbs down, and that aorta there's a carotid that climbs right off of the aorta, right off that main trunk, and goes right into your ear. So that's actually fantastic for us, and that's why we have to stay on the left side, or that's why we chose the left side. Whereas to get to the right side, it actually first goes towards an artery that goes towards your arm first. So there's a branch, and then there's this another hard branch up to the right side. And so it actually changes the flow patterns of how it gets to your brain. So there's actually been multiple groups that have shown this using other technology that, wow, when you have an orthostatic situation, they're differentially affected. Actually, the left side has a bigger drop than the right side because it's actually providing more of the blood, and it has more of a kind of direct fluid dynamic path. So that is actually why we are only on the left side. And we have seen some literature that left is actually much more representative of total cerebral blood flow than right. So there's actually multiple data sets pointing to why we have to be on the left side. And we've also just seen that that correlates better.
Right. I see a question here. They're wanting to know what a person who's unaffected by these specific diagnoses might see in their data. And I know, Daniel, you've been wearing a device for much longer than I have. So what do you see as like a person without an orthostatic diagnosis?
It's actually been quite interesting. So there is kind of like, I think people have like varying flow drops and ups that like if it might not be at the level of like clinical significance that you are going to go and see a doctor that something's wrong. But like for me personally, I see like, for example, I sometimes if I food coma or eat too much like carbs during lunch, I have a crash and like 1, 2 o'clock, I'm like, I have to take a nap. I'm like falling asleep and I see my flow is crashing at that time. I also see like there's various like caffeine effects. I see that as well of going up. I see some of these things that are actually helping me actually more from a like a cognition optimization standpoint to try to work more efficiently. I'm like, oh my gosh, I need to stop like sitting in the sun and having the sun come down on me and cause me to vasodilate and reduce my flow in the afternoon too. Like that's also messing me up from like feeling like at my top cognitive performance. And so it's been kind of an interesting journey myself for seeing some of these effects, but my drops are not as severe. That's as like what Shivani is demonstrating. That said, Shivani, yeah, like Shivani, but but my I have seen that. I mean, it might be possible that I also have some level of. I mean, I have had syncope multiple times before, so I might be closer towards that. Possibly not as but not maybe as clinical level, but like enough that I see more of a flow effect. So I'm sure it varies, but for me, I have seen that, and I would not classify myself as having dysautonomia.
Yeah, that's fascinating. It really points to how, long run, this could be a device that many different types of people could find useful. And I believe the latest statistic, Dr. Miller, correct me, but I think Dysautonomia International has been saying there's 40 million Americans with dysautonomia, and those are the people who are diagnosed. Mm-hmm. So if so many people might be undiagnosed, it seems like the need could be quite vast.
Yeah, so just evaluating people in the general population, we find about a 1%. Prevalence in people who aren't diagnosed.
Daniel, can you speak to skin color? Will Lumia work in people of all different skin colors?
Yeah, so unlike actually most wearables that are using a green light for how they try to shine and interrogate like the blood vessels, we actually use infrared light, which is much more, it goes right much more through like melanin and various darker skin tones. So that's one portion that makes us actually a lot less susceptible to some of the like skin tone color light issues. The other dynamic there is the level of skin that we're going through is like only a 1 to 2 millimeters thick. If you saw that picture of the ear artery, it's very, very shallow. You can basically see it if you backlight a light on your ear, you'll see actually your arteries. And so that's even with like, if you did a green light, you'll see that. So that's where that being in the ear lets us actually see, not have, like light goes right through very thin skin, especially when it's infrared. So we've seen this also in our, like empirically on people with darker skin tone. Good.
That's good to know. So we're seeing quite a few questions about, what about this treatment? What about that treatment? What are you seeing in the Lumia data? So specifically, people are asking about vagus nerve stimulation. Does that improve flow? The Q collar, does that improve flow? I would say my quick answer to almost all of this is that until, this current week, really, I've been the only person with these conditions to be wearing it. And there's been a limited repertoire of different testing that I've been able to put myself through while also holding down a job and doing all the things. So the answer is so many of these things we don't know yet. And I believe our beta period is going to be incredibly exciting, as will the first several cohorts of people receiving Lumia devices who pre-ordered last year, as we discover together all of these people, to the extent that they would like to share their experiences, if they decide they want to share their data, we do have some wonderful Facebook groups for people who have ordered a Lumia device, where that sharing of experience is going to unfold. And I think that's where we can start to see which interventions any individuals are finding helpful or less helpful for their own self-management of their symptoms. And then separately, on the research side, this is where Dr. Miller and our own Lumia research team, all the collaborations that we're lining up to start to study different possibilities for what Lumia can observe in real people under different circumstances. It's just going to be a whole new world for discovery. Is there anything else you might want to add to that?
No. I think it's solid. I mean, we're
Yeah.
also kind of running out of time here, so
Yeah.
we want to answer
was
maybe
one
one or two.
last.
Yep.
Yeah, maybe just a couple more. There was a question about notifications and nudges coming up on Apple Watch. I can confirm that any notifications that are pushed through the iPhone should come up on your compatible smartwatch. And for me, I do get my Lumia notifications on my Apple Watch. But Daniel, a few people are asking about the timing of alerts, how fast alerts, how can they manage their alerts? Could you speak to maybe both our current capability during beta as well as where that's going to be evolving to?
Yeah, we actually want to stay away from the term alerts because that can get into an FDA medical device classification. So it's not a medical alert. That's why we lovingly call them nudges. But there is a bit of a time delay with our nudges. That like right now, for example, I mean, this will of course change. Like betas can experience one like earlier version. Later on, we'll have more faster reactive, but it can't go faster than the sampling rate. So if we sample once every 5 minutes, then we might not see anything for 5 minutes. And if you had an event that it can happen, and like you stand up and within 2-3 minutes, even less, you could have a syncope episode. That's possible. So we're not actually at the start really functionally useful for like a in the moment syncope prevention. We have seen promise for that we could possibly measure that in previous research, but that's not how it's currently implemented in the initial feature set. So there is a time delay, basically 5-ish minutes if you're near your base station / phone.
Yeah, I think the usefulness there is going to be able to track your trends over time to see like when you did something yesterday or earlier in the day, like what effect did that have on your blood flow?
We do hope to continue to expand the data feature set to be able to have more types of use cases that might have to serve different populations and like different subsets. But like for now, that's our base. And that's also just like, as we start, we have to build a base feature and expand from there. So that's where we are at the moment.
So we have so many amazing questions, actually. There's at least another 50 questions we haven't even touched yet. So what I'm thinking is, to respect the time of everyone here, let's perhaps close this webinar, but where can you get more information, right? So we at lumiahealth.com, we now have a blog as well as some research and science pages where we are sharing the latest data. So for example, the research, Dr. Miller, that you shared, we actually have the downloadable full-size PDF research poster from that, as well as another one that was research showing supine reduced flow in an individual with ME who was during an episode of induced PEM. So there's a lot of research that we'll be continuing to add to those pages. So I would say check out the website, lumiahealth.com, check out the blog, and then please subscribe to newsletters. I'm not sending things very often. It's been at best once a month. I'm hoping to increase publishing frequency as we go, but we've just been focused on, actually getting our platform ready for all of our beta members. And we also have our Facebook groups if you're on Facebook. So there's the Lumia Open Interest Facebook community that anyone can join. You don't have to have an order or spend any money to be a part of that one. And that's a great place to ask questions in a wonderful community of I think our community is some of the most interesting people because we're all dealing with extremely complex overlapping conditions and many of us have taken on this role of being a personal data scientist to explore how to feel better. So I would encourage you to join that Facebook group, or if you do have an existing Lumia order, you can join our Lumia members private community, which is just a more closed space. So you know that there aren't random people joining if you did want to share something a little bit more sensitive. So So we'll close here, and then yes, we'll try to cover a lot of these questions in those groups, and you're giving me lots of ideas for things we can discuss on our blog or continue to answer in our newsletters and FAQs on the website. So any last words, Dr. Miller and Daniel, before we close?
Well, thanks
All
everyone for
right.
staying
Well,
on
thank
and
you.
listening.
Yeah, thank you.
Thank you so much. I see a couple raised hands, but unfortunately we won't have time to take that. But please, actually, if you just take a second and punch that question into the Q&A, we'll be able to address it as we go forward. I'll try to share some FAQs in the Lumia Open Interest Facebook group. So thank you, everyone. Thank you, Dr. Miller. Thank you, Daniel. I've been Shivani Ugrin, and for more information, just check out lumiahealth.com, and we'll try to answer all your questions there. So thank you. Have a beautiful day.